So we ended our last slide and discussion with the physiologic effects of labor on the mother and the fetus, and we talked a little bit about the fetus as far as the fetal heart rate and circulation. And fetal respirations are going to hopefully occur once the fetus is exposed to the cool environment, the bright lights, different chemoreceptors, and then the fluid that was in the fetus lungs will eventually be cleared from crying, from being, from having the squeeze of the passageway or the vaginal birth. So those are some different things to think about when we're considering fetal respiration. Maternal adaptations, we talked about these very much earlier and what happens, so I'm not going to spend a lot of time addressing these again. We did talk about integumentary changes, her musculoskeletal changing, really the endocrine changes, the progesterone levels and estrogen levels and prostaglandins are going to be very much utilized during labor and delivery. So we will see many different physiologic changes during mom and baby. As we discuss the factors of true and false labor, we need to think about, how are we going to determine what's different? How do we educate mothers to know if she's in labor, if it's just false labor? So we need to think about that, and as nurses you need to be aware of these things. So when we think about false labor, the thing to remember about with false labor is that there's no cervical change. So if a woman does come in and she's having a nice contraction pattern and we check her cervix, we'll probably keep her there, another hour, hour and a half, sometimes 2 hours, depending on your physician. And then we're going to recheck her, do another sterile vaginal exam. We're going to recheck her again. And if her cervix hasn't changed at all, we're going to go ahead and let her be discharged. We're going to go ahead and discharge her home. She's not going to like it, but if she's not making any cervical change, there's really nothing we're going to do for her differently at the hospital. With false labor, the contractions are usually irregular. They don't increase. They don't get worse. They don't come closer together. And then when she gets up and ambulates or gets up and goes to the bathroom, a lot of times those contractions will decrease. So true labor, we're going to see contractions becoming increasingly painful. So the intensity is going to increase, the frequency is going to get closer together, and we're going to have that cervical change. So a woman comes in having contractions and we're trying to rule it as labor or false labor. We're going to check her cervix. Again, if she has cervical change, then we know she's progressing in labor. Bloody show will be present. Bloody show is due to the breaking of the microcapillaries on the cervix during the labor and delivery and cervical effacement and dilatation process. And so she will probably have bloody show. And then the walking will cause those contractions to become even more intense. So some things that you do need to be aware of for the exam, these right here, signs of impending labor. So lightening, that's when the baby kind of engages and falls into her pelvis a little deeper. The Braxton Hicks become more frequent. She has a loss of the mucus plug, bloody show of weight loss, nesting or that surge of energy where she cleans everything. She packs bags, repacks bags, unpacks bags, backaches, urinary frequency, and then eventually the rupture of membranes. We will watch a video that discusses the various stages and phases of a laboring woman, but you do need to be aware of the stages. So you have first, second, third, and fourth stage of labor. And then within the first stage, we have some phases. And so you do need to be aware of the difference between these phases and then these actual stages of labor and delivery. So the first stage is where complete dilatation and effacement takes place. So in that first stage, there are 3 phases. The latent phase, 0 to 3 centimeters. Her contractions aren't very intense. Usually during this latent phase of labor, we want her to stay home. We want her to be comfortable at home, be able to walk, be able to move, and do those types of things. Active phase is 4 to 7 centimeters. And during the active phase, she's getting really uncomfortable. It seems like The active phase really takes the longest. It's the longest time for cervical dilatation, and she is really pretty uncomfortable. And then that transition phase, where she goes from 8 to 10 centimeters, usually that happens pretty quickly, but it is very intense. So the intensity of those contractions is going to be worse, and she's going to be really uncomfortable, maybe getting out of control, those types of things. Second stage is the delivery of the infant. So from first stage, complete dilatation, to delivery of the infant is second stage, and that's where she's going to be pushing. And second stage can range from a minute to a couple of hours. So second stage is pushing, and then the delivery of the infant. Third stage, delivery of the placenta. And then the fourth stage is that immediate postpartum period, and usually spreads out about 4 hours postpartum. We did talk about the admission process of the laboring client, and I don't think I'm going to spend any more time on this because I have discussed it already. But I would say make sure you're reviewing those laboratories and diagnostic tests in the prenatal record that we talked about, as far as her ABO and RH. We need to know if she's group B strep positive. We want to know her hemoglobin hematocrit. Make sure we have the proper ID band on her. Checking for rupture of membranes, checking her fetal heart tone, getting her hooked up to the monitor, those such things. With the cultural differences, I don't really have anything to address to this slide per se. It is on page 447 of your text. Make sure that you respect their privacy and just ask additional questions if you're not sure. If there's going to be cultural differences or things that you need to be aware of so that you are providing culturally competent care. Make sure that you do have a language line or interpreter readily available for our non-English speaking families. When we're describing nursing assessments, in chapter 18, it talks about nursing care on table 18.4. So when we're talking about nursing assessments, things that will increase the well-being of our mom, things that will enhance circulation to our fetus. We know that positioning and position changes are really important. So really, if she's on, a right lateral or left lateral, semi-fowlers, high fowlers, on the ball, ambulating, those types of things. Those things are going to help her feel better because she's going to be able to tolerate labor and delivery better when she's able to move around and not necessarily just lay in the bed and have to feel the contractions and really not be able to do anything about them. For INO, we do request oftentimes that women have clear liquids or ice chips and water. And really, if they get very hungry, really what I say to them is, if you don't want to vomit this food up later, then I would suggest that you stay, pretty much clear liquids and ice chips. Again, emptying the bladder every couple of hours is going to be important. So different positionings, side lying. Otherwise, if we can have her up and ambulating, that's going to be good. Definitely not lying on her back because of that supine hypotension. These are just a couple of different pictures showing you that she can be up in the chair. She can be hands and knees kind of over the bed. So there are many, many different options that are going to be out there. The use of the birthing ball, this is further in your notes, but the use of the birthing ball is also another great opportunity for her to change positions. And really, when she's sitting on the birthing ball, it helps open up the pelvis. It relieves a lot of this back pressure. And really what you can do is, if you could picture a bed kind of in front of her, if you raise the bed up in the air, she can use that to lean on, to kind of drape her arms on to help support her when she's up on the ball. So those things are going to be, a couple of different things to think about. Ambulation is great. It helps increase gravity, puts more pressure on the cervix. It will help make contractions more effective. She should not be ambulating if she is ruptured and the fetus head is not engaged. If the fetus head is engaged and she would like to get up and walk, that is totally fine. But if the fetal head is not engaged down into that pelvis, she shouldn't be up walking because gravity can have a tendency to enhance the movement of that umbilical cord, and she could she could potentially have a cord prolapse. So otherwise, if we can get her up and moving, that would be great. Getting in the shower is good. She can't take a bath once she has ruptured membranes, but she can stand in the shower and do those types of things. So lots of different options for positioning. Your partograms, with partograms, they kind of map out what should be expected of a woman's labor. With partograms, really, you can see that it's a graphical view. And so when you're looking at these, I'll bring this one up here. So when you're looking at these, this is 0 centimeters dilated, and the number of hours go right here across the bottom. So what we're looking for is how long is it going to take a multiparous, a woman having multiple deliveries or more than one, how long is it going to take her to deliver? And so it goes in time up by, it goes by hours and then by centimeters. And you can see here, your multiparous woman is probably going to deliver a little bit faster than your primip. And so the partograms just kind of give us a picture view of maybe how she's progressing through labor. And truly, your electronic health records, when you start charting in those, that information will flow over onto a partogram, and then you can pull those up and look at those. With the partograms, or with women in labor, we should really see cervical change 1 centimeter every 1 to 2 hours, and that's how we kind of know that we are having effective contractions and maybe in a good labor pattern. So nursing interventions during labor and delivery, assessment of the mother, assessment of the fetus, and the environment. So it's again recalling that information that we talked about earlier. How often are you going to take vitals? How often are you going to chart on the fetal heart rate? Contractions, pain, activity. So be thinking about the assessment of the mother, assessing for her rupture, looking at those labs again. Assessment of the fetus, really when she is laboring, your assessments are going to go by fetal heart rate and your contraction patterns, and how is that fetus responding to those contractions. Assessment of the environment, you know, are there lots of visitors? Is the TV loud? Is it bright? You know, if you have a woman that's getting out of control as far as her pain level goes, and she's really apprehensive and anxious, you know, calm that environment down. Turn the lights down, play some soft music, you know, anything to try to help control some of that environmental stimuli. Also, she's probably going to tend to want to keep that room cool, and so you might have to throw on an extra coat. Dad might have to put on a blanket, but again, keeping her so she is comfortable. This is table 18.4 on page 547, so you can pause the video and take a look at that. Just talks about responsibilities of the nurse during the laboring process. As far as nursing support and physical care, you know, we want to help her maintain control. Oftentimes in the beginning or early stages, we kind of feel like we're in the way and we aren't really sure what our role is. But when a mother is really truly in labor, she wants a support person, and sometimes her support person isn't sure what he or she should be doing. So we're going to be the ones there to help her maintain control. We'd like to meet her expectations of the birthing and delivery process. We want to be non-judgmental. So it's all going back to the nursing code of ethics and thinking about empathy, respect, privacy, compassion, kindness, being a patient advocate, help her conserve her energy, try to cope with the pain, remind her and encourage her, empower her, let her know how great she's doing, and then really, you know, above all, safety and then privacy throughout the laboring process. For our fathers, then, you know, we want to orient them to the labor room and explain what everything, you know, explain the equipment, let them know where the cafeteria is, waiting rooms, toilets, those types of things. Respect his decisions as far as what he wants to do to help mom. So does he want to help cut the umbilical cord? Does he want to be the one rubbing her back and supporting her? Prepare him for the worst. Let him know that, you know, there might be times that mom's going to be out of control and she's going to swear and she's going to be really upset with you. But also acknowledge him, offer him blankets, offer him something cool to drink, those types of things, so that they, you know, so that he knows that you're there to help support him as well. And then just be supportive of them as a couple.